physicians, doctors. Welcome to chapter 11, which is the second part of endocrinology. And it's a big chunk, and I've included a lot of the important topics in this as well. And all of these are high yield. I've made tables about it, and the tables help me a lot to compare between other diseases and differentials and to rule out which is the right answer. So all of these, it's a pretty short chapter. However, it's very high yield, and all of the information is very important. So we'll be going over it, and I hope you guys can memorize these important facts from the tables. So let's begin. We start off with thyroid disorders. Most important being hyperthyroidism. So hyperthyroidism, there are three diseases that AMC loves to ask about: Graves' disease, toxic multinodular goiter, and thyroid storm. All right. The mechanism for Graves' disease is going to be TSH receptor antibodies, all right, which stimulate thyroid, and there's excess T3 and T4. Toxic multinodular goiter, as the name suggests, there's going to be multiple autonomous nodules producing excess thyroid hormones. Then thyroid storm, life-threatening thyrotoxicosis. Wertowski score is going to be more than or equal to 45. That means it's thyroid storm. Now, just a note about toxic multinodular goiter is that we have a few tests which we'll be going over. But one of them is going to be radioiodide test, where we check the function of the thyroid as well. And in those, we can see that there are two different kinds of images that we see. We see a hot nodule and a cold nodule. Now, I want you to comment down below which you think is more dangerous. Are the hot nodules more dangerous, or are the cold nodules more dangerous? All right, and then I'll reveal the answer in a few hours, and we'll have a discussion about that as well in the comment section. Hopefully a productive one, which you can take important information home with it. Now, the typical patient for Graves' disease is going to be young middle-aged female with a diffuse goiter, whereas for TMG it's going to be older patients with nodular goiter, often iodine deficient areas. Thyroid storm is going to be any severe hyperthyroid plus a precipitant such as surgery, infection, radioiodine, or iodinated contrasts. Special features for Graves' disease is exophthalmos or proptosis, peritibial myxedema, and thyroid brute. Whereas for TMG we don't have any specific ophthalmopathy or dermopathy. Whereas for thyroid storm, again, it's a storm. We're going to have fever, we're going to have tachycardia, we may have AF, agitations, confusion, vomiting, and liver failure. And that's why we were discussing about the arrhythmias. We said that if they have any underlying thyroid conditions, you have to address that as well. And TSH, T4, T3, so TSH is going to be suppressed, whereas T4 and T3 is elevated. And then in TMG, TSH is suppressed again, and T43 is elevated. And again, same thing for the thyroid storm. TSH is suppressed, whereas T4 and T3 is very high. All right. Treatment for Graves' disease is going to be carbimazole or propylthiouracil, PTU first line in pregnancy. All right, and in thyroid storm, and propranolol for symptom control, and radioiodide is going to be definitive, and so is thyroidectomy. Then for TMG, it's going to be radioiodine or thyroidectomy, carbimazole for medical control. So if we want to give them a thyroidectomy, we have to get them under control. So medical control, we use carbimazole. Then for thyroid storm, first line PTU, 600 mg loading, then 200 mg. All right, now this is important regimen because I've seen questions about 600 mg, then 200 mg, and 4 to 6. Then glucose iodine after PTU. Then we have propranolol IV, hydrocortisone 100 mg IV again, and then we treat the precipitants, especially in the ICU. Then drug in pregnancy. Then the drug in pregnancy is going to be PTU in the first trimester. Carbimazole is teratogenic in T1, and aplasia acutis can occur, and carbimazole in the second and third trimester. All right, so first trimester PTU, second, third is carbimazole. Then for TMG, it's going to be radioiodide is contraindicated in pregnancy. Then thyroid storm, PTU in pregnancy. It crosses the placenta less, but it's a thyroid storm. It's an emergency. We have to do something. All right, so that's all of the important points for the three different types of hyperthyroidism that AMC asks about. Moving on to hypothyroidism, most common cause is going to be Hashimoto's thyroiditis. It is autoimmune mediated. We will see anti-TPO antibodies, anti-thyroglobulin antibodies, and also post-radioiodine and post-thyroidectomy we can see hypothyroidism because of iodine, global iodine deficiency, and lithium and amiodarone medications as well. Clinical features is going to be the classic cold intolerance, weight gain, fatigue, constipation, hair loss, especially in the outer one-third eyebrow, dry skin, bradycardia, slow reflexes, and hoarse voice with periorbital edema and non-pitting edema, and carpal tunnel syndrome is also seen. Then the diagnosis is going to be with elevated TSH, but free T4 is going to be low. This means that the hypothyroidism is primary. However, if TSH is elevated and normal T4 is the T4 is normal, then we have something called subclinical hypothyroidism, and we treat if it's symptomatic or TSH is going high and it's more than 10. Then myxedema, coma, it's severe hypothyroidism leading to hypothermia, bradycardia, hypotension, altered GCS. It's an emergency where we have to give IV thyroxine T4 plus T3 if it's available, IV hydrocortisone in cases of coexisting adrenal insufficiency, and warm the patient slowly. And since it's an emergency, we have to transfer them to the ICU as well. All right. The treatment, normal treatment for normal patients that are not in myxedema coma, we give them T4 or levothyroxine, and we start slow or we start low at 25 to 50 mcg OD, increase by 25 mcg every 4 to 6 weeks until the TSH normalizes. The target TSH is supposed to be 0.5 to 2.5 MIU per liter, and we take these in the morning 30 to 60 minutes before food. All right. Now the subclinical hypothyroidism, its TSH is 4.5 to 10 plus normal T4. We observe or treat if the patient is symptomatic, if the patient is pregnant, or the TSH goes above 10. Amiodarone in thyroid, because amiodarone can cause both hyperthyroidism with type 1 where if it's iodine induced, and type 2 because of destructive thyroiditis and hypothyroidism. All right. We monitor the TFTs every 6 months, and we do not stop amiodarone without specialist advice. All right. Okay, good. So now we know that amiodarone is a drug we need to keep a lookout for. If the patient is taking it, we have to check their thyroid function as well. Now, adrenal disorders, we move on to Addison's disease, which is primary adrenal insufficiency. So what does the adrenal gland do? It produces adrenaline, and because of the adrenaline, we have a few functions, and if there's a deficiency, we will not have those functions. Simple. So Addison's disease, so it's going to, it's the mechanism is autoimmune destruction of the adrenal cortex, most common in developed world, and also TB, which is most common worldwide. It can also be due to hemorrhage, malignant infiltration, and bilateral adrenalectomy. Hormone deficiency, so cortisol, glucocorticoid, and aldosterone, mineralocorticoid, or both. All right, they could be deficient in primary versus secondary, where only the cortisol is deficient and the aldosterone is preserved. All right, then classic biochemistry is hyponatremia and hyperkalemia plus low cortisol plus high ACTH, and also we can have hypoglycemia, eosinophilia, and normocytic anemia. All right, hyperpigmentation, so the diagnostic feature is due to the excess ACTH and MSH, and both derive from POMC. It affects the skin creases, we have buccal mucosa, we have scar tissue, and especially on the pressure areas. Then Addisonian crisis is acute adrenaline insufficiency leading to hypotension, leading to vomiting, abdominal pain, altered GCS. It's an emergency. We need to give them IV hydrocortisone, 100 mg stat, then 50 to 100 mg every 6 to 8 hours. Then IV 0.9% NaCl 1 liter rapidly. Then 50 ml 50% dextrose if hypoglycemia, and we treat the precipitant factors for these. Then the diagnosis for Addison's disease is going to be random cortisol less than 100 nanomole per liter in the morning, means adrenal insufficiency, which is the goal. The gold standard would be the short Sinathin test, which is 250 mcg ACTH IV IM, and the cortisol is going to be less than 550 nanomole per liter at 30 to 60 minutes after the ACTH has been given, which means that there is inadequate response, and that means there is adrenal insufficiency. Then the long-term treatment for Addison's disease is going to be hydrocortisone. It replaces the cortisol, all right, OD morning, plus 5 to 10 mg in the afternoon, plus fludrocortisone, which replaces the aldosterone. So both the cortisol and the aldosterone are being replaced. All right, and now this is pretty easy for all of the endocrine pathologies. If something is less, we replace it. If something is more, we try to reduce it. So in this case, cortisol and aldosterone are low, so we are replacing those. All right, now the sick day rule is that we double or triple the steroid dose with illness, surgery, and trauma. All right, this is an important rule. Now, Cushing disease is opposite of Addison's disease, and we need to make a difference between Cushing's disease and Cushing's syndrome. Cushing's syndrome is just excess cortisol from any cause, whereas Cushing's disease is because of pituitary ACTH secreting adenoma causing bilateral adrenal hyperplasia, and is the most common endogenous cause in 70% of the cases. Then clinical features: central obesity, moon face, buffalo hump, purple striae, proximal myopathy, hypertension, diabetes, osteoporosis, easy bruising, and thin skin, acne, and hirsutism. These are the definitive descriptions of patients that have Cushing's syndrome or Cushing's disease. Then the screening test we have is going to be 24-hour urinary free cortisol, which is going to be elevated, or overnight low-dose dexamethasone suppression test. All right, important. Both of these are important. Then we give them 1 mg dexamethasone at midnight, and at 8 a.m. the cortisol is going to be more than 50 nanoliter. It means it fails to suppress, and that means this person has Cushing's syndrome or disease. All right, the differentiation is going to be that the ACTH level, if it's elevated, then it's ACTH dependent or pituitary Cushing's disease, and if it's ectopic, then we have small cell lung carcinoid. And if the ACTH is suppressed, that means it's an ACTH independent disease, and that means it's probably adrenal adenoma or carcinoma. So if the ACTH is the one that's causing, if the ACTH is elevated, that means it's ACTH dependent. Then there's probably an adenoma or a malignancy in the pituitary gland. Whereas if the ACTH is normal, and that means that the disease is ACTH independent, that means that the adrenal gland is the one that has the problem. All right. Now the features, the treatment is going to be pituitary. For pituitary adenoma, we have to do transsphenoidal surgery, and before that we need to confirm by MRI. And for adrenal adenoma, we have to do adrenalectomy. Remember that we have to also make sure that we don't do a bilateral adrenalectomy. If we do, then we have to replace the hormones, or else if you're trying to treat Cushing's syndrome or Cushing's disease, will end up causing Addison's disease. Then if it's ectopic, we treat the primary presenting symptoms. If it's exogenous, such as if it's iatrogenic, then which is most common, we just taper the steroids the patient is taking. All right. And just to recap, Cushing syndrome is different from Cushing disease, is that Cushing syndrome is excessive cortisol from any cause, whereas Cushing's disease is endogenous. All right. Now, the important factors for primary hyperaldosteronism, which is known as Conn's syndrome, and Phaeochromocytoma. Just a brief overview for them. Conn's syndrome, the high yield summary is that it has a clinical triad. They'll have hypertension, hypokalemia, and low renin. All right, and the clue is that it's going to be progressive nocturia, weakness, and we check the serum potassium. Then the screening test for Conn's is going to be aldosterone renin ratio. If it's elevated, then we have primary hyperaldosteronism, and the causes are usually unilateral adenoma, or something called Conn's adenoma, or bilateral adrenal hyperplasia. The treatment, if it's unilateral, we go for laparoscopic adrenalectomy. If it's bilateral hyperplasia, we go for spironolactone. All right, again, tried hypertension, hypokalemia, and low renin, and there's going to be clinical clues such as progressive nocturia, weakness, and you have to check the serum potassium. All right, okay, good. Now moving on to phaeochromocytoma. Phaeochromocytoma has the 5 P's in it: paroxysmal hypertension, pounding headache, palpitation, pallor, and precipitation. Then the investigation is going to be 24-hour urine metanephrine, which is the most sensitive, and the plasma metanephrine concentration. Then we do a CT/MRI of the adrenal gland. It is critical that we use alpha blockers first, such as phenoxybenzamine, then beta blockers, then surgery. All right, so first is going to be alpha, then beta blockers, then finally surgery. All right, we never give beta blockers first, because that means that we'll have unopposed alpha that's going to cause hypertensive crisis for these patients. All right, okay, good. Now moving on to the worked MCQs. This is the last section of this chapter. We covered everything that was high yield from this particular chapter, so these are the worked MCQs. You guys can go over it, and after you guys go over it, read the explanation, try to guess the answers. And if you guys have any further questions, then feel free to drop them in the comment section, or message me on WhatsApp, or send a message on the Telegram group. Again, all the resources are completely available. They're in the description, pinned in the comments, or they're available in the Telegram group. Just check it out. And if you guys have any questions, just leave them down below. And hope you guys enjoyed this revision, or learned something, or revised properly with me. Thank you.